Welcome to today's webinar on avoiding preventable death using the health risk screening tool, a review of the latest mortality research. I'm Dr. Craig Escude, president of Intellectability, and I'll start by telling you just a little bit about Intellectability. Most of you know about our health risk screening tool. That is our primary service brand, and we'll talk more about the health risk screening tool today. We also have two other service brands, our Academy division, which focuses on supporting supporters by providing education and training related to health-related issues and health-related risks in people with intellectual and developmental disabilities. It consists of a number of e-learn courses that are available to use for that purpose. And our Person-Centered Services division helps transform organizations to providing more person-centered focused supports and services to people with intellectual and developmental disabilities. Before we get started, we'll go over a little bit of webinar troubleshooting. If the audio stops working, check your speaker volume, check your mute function. You might check your speaker selection. If none of those work, you might have to close and restart the webinar, or you can restart your computer. If the video freezes, I would try closing and restarting the webinar, or you may also have to restart your computer if that doesn't work. I'll also mention here that there are handouts available consisting of the PowerPoint of this presentation and some other information, and that is available in your control panel under the handouts. So be sure and check that today. So a little bit about our presenters. As I mentioned, I am Craig Escude. I'm a board-certified fellow of the American Academy of Family Physicians and the American Academy of Developmental Medicine. I've practiced clinically for over 20 years, providing healthcare to people with serious mental illness and complex medical conditions, as well as people with severe and profound levels of intellectual and developmental disabilities. As the medical director of Hudspeth Regional Center, I retired in 2018 and came to work with Intellectability. I'm also the author of the Clinical Pearls in IDD Healthcare and the Curriculum in IDD Healthcare. And I will turn it over to our co-presenter today, Jonathan Crumley, to introduce himself.
Thank you, Craig. My name is Jonathan Crumley. I am the Chief Operations Officer for Intellectability. I have been in the field since the early 2000s. I started my career as a support coordinator in the state of Georgia, and for many years there, I was the Vice President of Georgia Support Services. While there, I was also a supports intensity scale trainer with AAIDD, doing quite a bit of work in the United States and Canada. I am a currently trained person-centered thinking trainer through the learning community for person-centered practices. And as I mentioned, I've been with Intellectability now for about 10 years as the Chief Operations Officer.
Thanks, Jonathan. So I'm going to start off by talking about an old study. We like to talk about current studies, of course, but this one bears certainly is interesting and worth talking about here. This is something called the Hodges report, which was published in 1984 by the Brehon Institute of Human Services. Back in 1982, there were a number of people with intellectual and developmental disabilities that were moved out of a couple of institutions into community settings at 6 separate sites in Florida. What was noted was that there was a very high death rate at one of the sites, called the Hodges site, within the first few months. They looked at reasons for this, and it was not explained by higher rates of medical fragility or medical complexity, but rather that the Hodges site had a smaller, less well-trained, more unstable workforce with high staff turnover and fewer staff on at any given shift than other similar entities. Now, the reason I'm talking about this, because doesn't that sound very similar to what's been happening in the past few years with the COVID pandemic? We've had a very hard time maintaining staff and providing, potentially or having a lot of staff overturn in staff, making it challenging. And what was observed, there were some steps to successful oversight that were identified as a result of this study. And I want to go over those today because these steps actually were very foundational in the formation and the creation of the health risk screening tool. So the first one is to always know if a person's condition is getting better or if it's getting worse. So basically know the health status of the people that you're supporting. Have an early warning system to detect health stabilization. Have some mechanism to identify when people's health is changing. Don't let chronic health conditions or issues become routine or invisible. Don't forget that chronic health conditions can suddenly worsen sometimes. The records must provide useful data about trends, and that's one of the things that the health risk screening tool can do. And to ensure continuity of care across providers, so that when a person moves from one level of service to another, there is some sort of information that can be transferred with that person that provides a good picture of that person's health status. And then also to monitor residential settings to assure health and safety. So I think this study, even though it's back in the 80s, has a lot of relevance now because we're seeing some of the same issues with staffing. Now, a few other studies. Studies have shown that people with IDD utilize emergency departments at higher rates. They have a higher risk of death in hospitals. They're twice as likely to die from preventable causes. And what we're talking about here primarily are the fatal 5+ that we talk about: aspiration and seizures and dehydration and constipation, bowel obstruction, sepsis, gastroesophageal reflux disease. And they also are known to experience poorer health outcomes in general. So we're going to talk today about the mortality study, and also about the health risk screening tool, which again was developed to address many of these issues that we just talked about. So what is the health risk screening tool? Again, I know many of you are users of the health risk screening tool, and it is a web-based tool that is designed to identify health risks, to identify that change in health status, and in people with intellectual and developmental disabilities, but it's also applicable to people with physical disabilities, with traumatic brain injury, with disabilities associated with aging, and really any at-risk population. It not only identifies those health risks, but it also provides actionable steps that support staff can take to help mitigate those risks based on each person's specific risk profile. So the health risk screening tool consists of 22 different areas of risk that are rated. And once all of those areas are rated, a person is assigned an overall health care level. That ranges from 1 through 6. In general, healthcare levels 1 and 2 indicate a low risk. Healthcare levels 3 and 4 are a moderate risk, and healthcare levels 5 and 6 indicate those that are at highest risk. And we'll be talking about those health care levels in a little bit and how they relate to mortality. So getting to the studies part of this, there's been independent research done. There have been 2 studies completed independent of one another by the Center for Outcome Analysis and by the Georgia Department of Behavioral Health and Developmental Disabilities. One of these studies analyzed yearly mortality trends, which is the Georgia study, and the other study focused on life expectancy. It's focused on life expectancy trends over about a 9-year time span. The focus was on people with intellectual and developmental disabilities who were fully screened using the health risk screening tool. Both of these studies independently supported a correlation between the health risk screening tool healthcare level, that's those levels 1 through 6 that I just mentioned, and mortality dynamics. This study was published in the Journal of Nursing Measurement, and that's what we're going to talk about the mortality studies today, primarily the Georgia Department of Behavioral Health and Developmental Disabilities research. But the study was published in 2020 in the peer-reviewed Journal of Nursing Measurement. And if I can summarize that study in one sentence, the conclusion was that, and this is a quote from the researchers, the HRST can predict mortality. Therefore, it can serve as a basis for establishing healthcare needs and determining nursing care acuity. So let's just talk a little bit about the mortality causes in general and what was looked at in this particular Georgia study. So there were factors that were analyzed relating to mortality. They were looked at either individually or pairing them together. And those factors were age, gender, the region in the state that the person was served, the intensity of the residential setting, the health care level from the health risk screening tool, and also COVID-19 was factored in. And only the increasing age and the HRST healthcare level scores were significantly associated with the occurrence of death out of all of those factors. Those other factors were not significantly related to mortality in 2021. So what we want to do is delve into the data a little bit more. And to do that, I'm going to turn it over to Jonathan.
Thanks, Craig. Yeah, so I want to spend the next few slides kind of taking you through the data that was in the latest mortality report from Georgia. I'm going to take a look at a few graphs and kind of go through and kind of dissect what these graphs are telling us in relation to the health risk screening tool, particularly the health care level that Craig was just talking about. Now, before we do this, I always like to start with a little bit of a definition here, because you're going to hear me use the term crude mortality rate a number of different times as we go through the next handful of slides. And so I want to give you a definition of what that is, so that when you see these crude mortality rate numbers on these graphs, you understand that how these numbers were derived and what they actually mean. So very simply put, the definition that we're looking at here for crude mortality rate is the number of deaths per 1,000. So a crude mortality rate is calculated by dividing the total number of deaths in a specified time period, such as a year is what we're looking at here, by the total number of people in the population who died, and then multiplying that by a constant, in this case, 1,000. So that number that is generated from that equation is what is called the crude mortality rate, and that's what we're going to be looking at here. Now, an example that I can give you specifically from this particular year, 2021, in Georgia, as you will see if you were to read the mortality report, is in 2021, DBHDD served 13,841 adults. Those are characterized as those that are at least 18 years of age and older, with intellectual and developmental disabilities in their waiver service program. Now, out of that 13,841, there was a total of 297 deaths that occurred in 2021. So the 2021 mortality rate was 21.5 deaths per 1,000 individuals. And again, going back to that calculation that I was just working through, this is how we calculate that. We take that 297 deaths divided into that total population of 13,841, we get 0.02145, and when that is multiplied by 1,000, you get 21.5. We're going to come back to this number here, 21.5, in just a moment, because that's going to show some significant things that we'll want to look at when it comes to looking at all of the healthcare levels across the entire spectrum, from healthcare level 1 all the way up to healthcare level 6. So let's move into looking at some trends. But before I do that, I want to point out a couple of things that I'd like you to keep in mind as we review this data. So as Craig mentioned, this data is from Georgia. Now, in Georgia, the HRST rater, which is the person that is trained to do the HRST screening, are non-clinical staff at the provider level. So we think about staff like DDPs, DSPs, house managers. Georgia utilizes a model where the HRST rater is those key provider level staff that know the person really well. So all of the data that you're going to be seeing today is reflective of screenings that were done by non-clinical staff. Now, one of the reasons I want to mention this is because sometimes non-clinical staff will voice concerns about screening or about administering the HRST in light of the fact that they themselves are not clinicians and the HRST is a clinical type tool, and yet they don't have a clinical background. But a couple of things that I want us to remember is remember the HRST was designed from its inception to be a screening tool, not an assessment or not a medical clinical type assessment. I also want us to remember that it was designed to be administered by supporters who do not have or are not likely to have a clinical background. So if we were to go back into more of the history of the HRST, one of the situations that necessitated the HRST be a non-clinical friendly document was the fact that the whole point was to really put a valid tool in the hands of folks that are very close to the person, support the person on a day-to-day basis, but may not have a lot of clinical background or any clinical background at all, but to really put into their hands a tool that could be that was validated, and it was very reliable in terms of noticing where risk is, how intense that risk is, and if patterns of risk are emerging. And that is where the HRST came from and how it was designed and how it was created. So with that, one could also argue, and rightfully so, that the training of the raters, that the training the raters receive to even be able to screen the HRST is that basic clinical training, basic clinical exposure that anyone needs to have who is going to offer support to, in this case, people with intellectual and developmental disabilities, because that health risk can manifest so differently in this population. And so the training that raters go through to be able to screen is that basic clinical awareness, that basic clinical training on some of the things that Craig mentioned, like aspiration and such rating items as eating and ambulation and transfer. So even though the person may come to the field, and most of us do, with no clinical background or maybe no previous exposure to people with intellectual and developmental disabilities, this training equips raters to be able to identify and have just enough clinical knowledge that they can use the screening tool, and really the tool does all of the work in terms of identifying the risk and where that risk is. So as we look at the reliability of this data, and you'll see that year after year, as we look at these repeatable trends, it's good to remember that these screenings that you're going to be looking at the data on here today are not being conducted by nurses, they're not being conducted by doctors, they're not being conducted by people with advanced clinical exposure, but rather folks like me and like many of you perhaps watching this webinar who do not have a lot of clinical expertise or experience, or who do not have a lot of clinical background. So with that, let's now look at the data, because I really think it's important to understand that what you're going to see here is data that is coming from folks who are raters who do not have that clinical background. All right, let's look at the first graph. So the first graph shows the data from not only 2021, but also 2020, 2019, and 2018. Now, the first thing I'd like to say about this graph is what you're going to notice is that these lines from year to year are very close to one another. Now, what that immediately tells us is that these healthcare levels are doing precisely what they should do. As healthcare levels increase, so do the number of deaths as represented by each of the healthcare levels there, as you can see, 1 through 6, and each respective healthcare level's crude mortality rate. Now, keep in mind, the only way a healthcare level increases is for the scores that are assigned to those 22 rating items to increase. The only way for scores of rating items to increase is for the tool to detect risk or patterns of risk or destabilization. So what we're seeing here is increased risk that is of healthcare levels manifested through increased scores because there is an increased presence of risk. And so as you see in the graph, as you go from healthcare level 1 to 2, 3 to 4, 4 to 5, 5 to 6, that risk is increasing. And with that increased risk is the increased likelihood of death and mortality risk. Now, this is significant to note because based on the scores of the 22 rating items, which drive this healthcare level, when you get to healthcare levels 3 and above, 3, 4, 5, and 6, there is enough cumulative risk in those 22 rating items that it is driving that healthcare level up. And as you can see, when you get to healthcare level 3, 4, 5, and 6, the trending of the data goes sharply upward, meaning that the likelihood of death from health risk goes up when you hit those higher healthcare levels. Now, the takeaway from this graph is, number one, is the consistency year after year, keeping in mind that the people who rated these folks are non-clinical staff, but yet consistently year after year, the healthcare levels are reliable and the data year after year shows that. So if you're an HRST rater out there and you've joined us today on this webinar, what I want you to hear from this slide is an increased level of confidence that when you get a healthcare level with the HRST, assuming that you have done what you can do to make sure those scores of those 22 rating items are accurate, when you get a healthcare level, you can put stock in that healthcare level, that if that person screens a healthcare level 3, you can rely that healthcare level is accurate and it's been validated numerous times as being a solid indicator of overall risk for that person. It finally takes the subjectivity out of the question, and what you're looking at here is not only objective yes or no questions to get to a score, but an objective score overall, whether it's at the healthcare level or at the individual rating item level. Now, that's very important, because what we want to do here is when you screen the HRST, you need to have confidence that the outcome of the screening is something that you can base action on, which is part of what the HRST does. Getting a score, getting an accurate healthcare level is part one. That's the first thing to do. But then what the HRST tells you to do, or offers the troubleshooting guide through the service and training considerations in light of these scores, is really where you can go into action with the hope of, over time, bringing someone's healthcare level down from a healthcare level 3 to a healthcare level 2, and even better, a healthcare level 1, or from any higher healthcare level down to a lower healthcare level. So this is very interesting data. What you're seeing in the column there on the left-hand side is that crude mortality rate for each of the healthcare levels for 2021, and you're seeing that respectively for each of the healthcare levels. So this is how the data trends year after year, which should increase our confidence that the HRST is doing exactly what it was supposed to do, and that is provide a very reliable indicator of risk, even if the rater is a non-clinical person.
And Jonathan, I just want to piggyback on what you said there about, that's the risk if nothing's done. And that's so important to understand, that it identifies that health risks, the risk, that's associated with mortality for each person. And that's if nothing is done. And so the idea is to identify those that have highest risk and do what you can, including using the service and training considerations in the health risk screening tool to help reduce that person's risk of death. Yeah,
that's it. Exactly right. The power of the HRST is to give you a reliable score, but then the real power of the tool is to give you those possible solutions that you can track down to find out what's causing this risk and to do something about the risk, instead of many times treating the symptoms or the behavioral manifestations that come with some of these health risks. But really, as Craig said, to get to that root cause and change the narrative, change the future, change the outcome for the person, so that their healthcare level doesn't continue to rise and their risk of dying does not continue to rise as well. What you're looking at here is just the data from 2021. See there, healthcare levels 1 through 6. Again, each healthcare level's respective crude mortality rate. But what I've done here is we've done an overlay of the overall crude mortality rate for the entire healthcare 1 through 6, and that 21.5, and laid it over the 2021 data. Now, why we do this is we can see that overall crude mortality rate that you're seeing there in that 21.5, it hovers just above healthcare level 3. Now, that is significant, because it has always been known, and even from the early days, the creator of the health risk screening tool, Karen Green McGowan, always knew that healthcare level 3 would be a bit of a breaking point, where when people are accumulating enough raw scores at the rating item level to reach a healthcare level 3, enough destabilization is occurring, enough risk is occurring, and enough patterns of risk are manifesting that the person is in trouble or they're headed in a bad direction, particularly if that healthcare level continues to go upward. Now, another thing to note here, in addition to just knowing that this data again tells us what we've already have known for years, and that is healthcare level is that bit of a breaking point. But I also want to pull your attention to healthcare level 4. Notice how steep the increase is in the crude mortality rate with healthcare level 4 and that overall crude mortality rate, and even the difference between 3 and 4. Now, with healthcare level 4, we call this the insidious healthcare level because with healthcare level 4, it has long time been associated with unexpected, unplanned, unpredicted death related to hidden, less obvious risk. So the narrative that oftentimes plays out for folks who pass away and die at a healthcare level 4 is that these folks appeared to be very well. They appeared on the outside to be doing quite well. Maybe it was just business as usual. The person gets sick, or perhaps they have some type of acute health event, and then from that, they never recover. And it's only in the post-mortem review that it's fully discovered that the person was showing warning signs of health destabilization and health risk all along. It just unfortunately wasn't being detected, or it wasn't unfortunately being placed on anybody's radar. So with healthcare level 4, we have to be extremely careful because it's almost like a transitional healthcare level where the person has already surpassed healthcare level 3, which is that breaking point. They haven't yet got to a healthcare level 5 or 6, but that healthcare level 4 can be quite insidious. And if you're out there and we'll talk about this in just a moment, but if you're supporting someone and that you feel that they are accurately screened and they're sitting at a healthcare level 3 or higher, but particularly at a healthcare level 4, this is an individual that you would want to give a lot of attention to and start probing into what rating items are driving that healthcare level up and what are the considerations telling you, because this is a person who more often than not with this particular healthcare level is in a very dangerous situation. So again, these healthcare levels 3, 4, 5, and 6 are those healthcare levels where we see that highest risk accumulated among the 22 rating items, which drives that healthcare level up, which in turn drives that risk of early death and mortality up. If we look at the last 5 years and we average out those years, which the individual years are those gray lines, but that average is that green line. Again, what we see is consistency. We put this graph in there to show that whether you're looking at 2021 or you're looking at a cumulative group of years, in this case, the last 5 years, the data still holds true, and it still holds reliably true from year to year. And that is these healthcare levels are doing exactly what they should, and they've got something to say if we will listen. So if you're out there and you're not using the HRST yet, or maybe you're considering the HRST, know that when these healthcare levels are generated for those you support, you can act with reliable confidence that the actions that you're taking are based off objective data that where true risk, true destabilization, true patterns of risk are emerging. And so that's what we see here as we look in this case over the last 5 years. I'd like to go over some key findings of the study with you, because this is going to really reinforce what we just saw in the last 3 slides as it relates to these graphs. Now, these are quotes, and many of these are directly from the mortality study, which, by the way, we will be providing you a copy of the mortality study in the handout section for you to review. But in 2021, each 1 unit increase in healthcare level was associated with a 54% increase in the odds of dying. Let's just stop right there and consider that. So if you have someone and last year they screened a healthcare level 1, and this year they're rescreened and they hit a healthcare level 2, the only way that can happen, the only way that healthcare level can increase is if those 22 rating item scores have increased in their individualized score. So even if the person is still technically in a low risk category, when we look at healthcare levels 1 and 2, as Craig was showing you earlier, those are low risk categories, right? Even a 1-point increase from a healthcare level 1 to healthcare level 2, the person is now 54% an increase in the odds of dying. Now, when we look at folks that may already be in a bad situation because they're sitting at a healthcare level 3, or let's say they're sitting at a healthcare level 4, and now their healthcare level has gone up to a 5, we really are looking at a dangerous situation, because this is a person who is already experiencing and manifesting various levels of health risk and destabilization, and now their healthcare level has increased yet again. And that's a person that definitely needs a support team around them that's looking at risk and looking at what is driving these risks, and really clinically advocating for that person, whether it's with a doctor or whomever, to get the right level of care to treat the right root cause. Now, results from previous years consistently show that a 2-point increase, again, so this is a person that maybe goes from a healthcare level 2, they're rescreened and they land at a 4, increase the health risk, and increase significantly the likelihood of mortality. So if you think about a person with 54% increase in the odds of dying just by increasing 1 point, a person who jumps a healthcare level altogether is definitely a person that is destabilizing, and they're destabilizing quickly, meaning even in the past year, they've jumped an entire healthcare level. Now, some of these things that's causing the person to jump healthcare levels may be on the radar of the support team, but then there may be other things that are driving these scores up that are not on the radar of the support team, and that would be where the team would want to rally around and find out, okay, we know about these risks and we're following up on those, but what other risks are present that the HRST is telling us that we don't have our attention on? So like in previous years, there was a statistical association between the HRST healthcare level and the mortality rate in 2021, just as in previous years. And in 2021, again, just like in previous years, individuals with a healthcare level of 3, 4, 5, or 6 had greater odds of mortality. And you saw that just a moment ago in the graphs. So that's very important key findings of the study. A couple more I want to share with you. We saw this in one of the graphs there, where the crude mortality rate, that overall crude mortality rate of 21.5, hovers just below, healthcare level hovers just below that overall crude mortality rate, which means that breaking point coincides with that overall crude mortality rate, which again is another vote of confidence that these healthcare levels are accurate and they're telling us exactly what we need to know. Increases in healthcare levels should prompt action to avert preventable death, even if it's a 1-point increase. We're just talking about this. We definitely don't want folks to think like this. Oh, well, Johnny was a healthcare level 1 last year. He's only gone up 1 level, so we're still in the low risk zone, so we're all good. Please, if you're on the call today and you're using the HRST and that has been the narrative or the vantage point that you've had, I hope you will hear me today say that is not a right perspective to have. A 1-point increase, even at lower healthcare levels, has that person's risk of dying has increased by 54%. So even at lower healthcare levels, that attention is needed. The same thing goes with rating item scores. If a person rated last year in an item A, eating, a 1, and this year they scored a 3, that is significant, because that means in that one rating item, their risk has gone up to a person who now is in a completely different risk profile and risk picture for that rating item than what they were last year. If that happens enough times over the course of those 22 rating items, it will impact that healthcare level, and that healthcare level will go up. So even if the healthcare level doesn't change, but scores have increased in those 22 rating items, go into action as to why are the scores increasing in these rating items, even if it's just by 1 point, because taking action at the rating item level, you can avoid that healthcare level from ever moving up to those higher healthcare levels. Now, 4 of the leading causes of death for DBHDD's IDD population were not common to the top causes of death in the US and specifically in Georgia. And those are sepsis, aspiration pneumonia, and seizures. And then also pneumonia and just overall disability. And 3 of these that are bolded there are part of the preventable fatal 5 that you oftentimes hear us talk about.
Jonathan, let me jump in here and
Sure.
just talk about that last one there, disability. I always like to make the point that really, having the disability itself really isn't the cause of death. It might be some complication or something related to the disability, but such as pneumonia or a seizure or something along those lines. But to say that the disability is the cause of death is a little unclear. And I do think it should be listed, for instance, on a death certificate in the other conditions that a person has. But typically, it's not something that we consider the cause of death. But we see this listed a lot from death certificate data.
Mm-hmm.
I would encourage people not to do that.
Very true. Now, also some other key points here when it relates to previous years. Increasing health risk and increasing age were most strongly associated with mortality. So you heard Craig talk about this in some of the earlier slides. When you think about those other factors that Craig talked about, like gender and region in the state, residential setting, even COVID-19, which you're probably sitting there just like us thinking, wow, if there was anything that we would have thought would have impacted and had a statistical significance, it would have been COVID-19, right? But these were not found to be significantly associated with the occurrence of death. It repetitively is always, as in previous years, increasing health risk and increasing age. Now, speaking of age, as age and healthcare level increase, the likelihood of dying also increases, the study tells us. And we want to keep in mind that the average age of death for those with intellectual and developmental disabilities in 2021 in Georgia was only 54.6 years old. And this is pretty much, I think, the national standard here is around this age. Now, if you're hearing this for the first time and you think, my God, 54.6 years old, I'm already fill in the blank, then that's the type of response to have, because I'm 46, and when I see that the average lifespan is 54, or age is 54.6, then my reaction on that is, wow, if I were a person with intellectual and developmental disabilities and I was going to fit into the average, I don't have much time left. Now, if you're on this webinar today and you took the time to get on this webinar, you're probably like us, and our viewpoint on this is that for people with intellectual and developmental disabilities, for the average age of death to be 54.6 years old is just simply unacceptable. We can do better than this as a field, and we can do better than this in our overall care for people with intellectual and developmental disabilities. And the way we can do that is start identifying this risk early and start doing something about the risk early and keep those risks mitigated as much as possible and keep them from impacting increasing healthcare levels, because we know that people are just going to get older. Unfortunately, it's how the game is played. People are going to get older, but their healthcare level does not have to increase. We can stave off the healthcare level in most cases. Not all cases. Some people are going to have acute occurrences where healthcare levels are going to go up and there's going to be very little we can do about it. But for many of these folks that are dying of preventable causes, choking and dying when they didn't have to choke and die, things of that nature, we can go into action. We can be aware of the risk. We can prevent that healthcare level from going up. We can prevent people from dying of preventable causes. If we were successful in just that arena, just the areas where we can prevent it, you would see this average age of death go up significantly, which should be the goal of every one of us working in the field, whether you're on the side of working with a company like we are, or you're a direct care staff, or you're a case manager listening, or you're a provider administrator, or you're a state official, whatever that may look like, there is something we can all do to help increase this age, if at all possible. So we'll talk a little bit about the reality here.
Yep. And what we're talking about is the reality of the situation. We know that there are workforce challenges. There's no doubt about that. It's been very, very clear, and those workforce challenges existed before the pandemic, and the pandemic only succeeded in worsening them and making them more of a challenge. And when there are limited number of people, there are fewer eyes to notice health destabilization, to recognize that a person is declining. We know that direct support personnel, as well as nursing availability, it has been significantly limited. And that's why I talked about the Hodges report in the beginning, because those were some of the same factors that were identified that related to the higher death rate at the Hodges Center. And when we have fewer eyes, when we have fewer people trained to observe health decline, we see people that can silently decline without being detected, without it being observed. And then they're not recognized until they really get into trouble. And that really speaks towards the importance of using a tool like the health risk screening tool, or a validated, reliable health risk screening tool. It matters now more than ever because it can help clue staff into people that are at higher risk and help you focus your limited resources to areas where it can have the greatest effect.
Mm-hmm. That's right. And we can almost kind of think about, we all fall into two camps. And if you're supporting the person every day, then you may fall into one of these two camps where either you see the risk and you see the destabilization, but you don't know what to do about it. You don't know how to respond to it. Or you may be in the other camp where you see it, but you don't realize that it's even a problem. Perhaps you think, well, I guess people with intellectual and developmental disabilities just do this. I guess this is part of their life experience. So many times what we find is well-intentioned, good-intentioned people, they see things and they recognize something's wrong, but they don't know what to do about it, or they just don't recognize it because they don't have the right training, or that they don't have the right tools in their hand to be able to even know that something is the problem. And the HRST seeks to address either one of those two camps, regardless of which you're in. Let's talk about what we cannot do. Now, heads up here, I'm going to be preaching to the choir because I think there is a universal, maybe unspoken agreement that we all know that we cannot allow people to decline just because of high staff turnover and DSP shortages. Yes, these are real dynamics. Yes, there are real things. These are real, unlike ever before, perhaps, factors that are playing into how we do business every day. And we work in a lot of states, and we see some of the pain points that states are experiencing right now, where they have providers who are dropping people off at ERs and because they can't offer care anymore. But somehow in the midst of all of that, we still have to have our attention on where is the person declining, and not use these things as excuses not to screen the person, but use it as reasons to screen the person. Because if ever we needed a tool that could help us identify risk that's likely going to get missed because of some of the factors that Craig was talking about, it's now. So we don't want to use the environment and the ecosystem that we're living in right now as an excuse not to screen, but really a reason to screen because of just simply how this is impacting the system. We can't ignore our responsibility to ensure the person's health is attended to, and we cannot use these factors as an excuse to allow risk to just simply go unchecked or not responded to. There will always be a crisis in this field. Today, it's the direct support staff shortage and a number of different other post-COVID era implications and shockwaves. But when that dies down and when that goes away, rest assured there will be something else. But what the consistent response of supporters has to be is a commitment to not let any of these things deter them from, really overseeing the person's health and welfare to the best of their ability. And we really almost have to have the mindset that if my own family member was experiencing this decline. And there was a screening tool that I could use that would help me perhaps get to the root cause or shed light on what's causing the risk so that I could do something about it. If that were the story of our family or a brother or sister or mom or dad, we would screen them. Despite extenuating factors and despite difficulties, we would make sure that our family member got screened. We have to have that same type of mentality when it comes to those we support. As if they were our family member, we will make sure they get screened. We will make sure that we're identifying the risk. And that's really what we tell a lot of our clients that are using the HRST is have the same mentality that you would if it were your parents, if it were your brother, or your best friend, and so forth and so on. And so that with that mentality, even in the midst of these extenuating factors, people can get screened and their major health risk and destabilization factors can be addressed. Now, what we can do is we can ensure that the HRST is accurately rated and kept up to date. So if you're on this webinar today and you're an HRST rater, you can make sure to the best of your ability that that person's HRST is rated and kept up to date. We can identify people based off increase in scores and increase in healthcare levels who are experiencing more risk or jumps in risk just simply by what's happening to those scores, what's happening to those healthcare levels. And we can identify anyone with a healthcare level 3 or higher, particularly those in a healthcare level 4 situation. We can do that with the ease of just looking at the person's screen. And we can remember that updating the HRST, even if because of these extenuating circumstances, it can only be done once a year, that's better. An accurate screening once a year is better than not doing anything. Now, obviously, the ideal is throughout the year, the HRST is being updated to track with the person's destabilization or their change in health status. But even if that can't be done, making sure that at least once a year, the person is getting an accurate screening so that we can see what's happening to the scores of these rating items, what's happening to this healthcare level. And when we see shifts upward in scoring, we can do something about it. That is a reasonable thing to do, even if it's just once a year. We can find out which of those rating items are driving the healthcare level. We can use the information to change the culture of our agency to be proactive instead of reactive to these things. And we can use the health risk screening tool, training, service, and training considerations for guidance on how to act, how to respond to these risks that are being identified. So speaking of the service and training considerations, let me talk to you just a little bit about the training. If you are a current HRST user, you have access in your HRST web-based application to multiple training tutorials that you can take. One is on how to use the service and training considerations. There are others in there that can help you really bolster your ability to use the HRST. They're unlimited use. They're located under your profile, specifically under the trainings tab. You can take and retake them as much as you want to, and you can get information from them. Some of them even have handouts that you can download and take with you. Let me strongly encourage you you've been through online rater training, you know how to screen, perhaps you've even been through advanced rater training. Go in and take a look at these additional trainings that are in there because they can really help round out your ability to be a very effective HRST, a very accurate HRST rater. If you ever need help with the HRST, with accessing these trainings, all you got to do is reach into our support line, and our support teams will respond to you and give you all the help that you need.
Now, I want to tell you something exciting and new that's on the horizon related to the health risk screening tool. This is something called health risk informed telemedicine and also health risk informed medicine. You're going to be hearing a lot more about this, especially if you're attending conferences this year. We'll be speaking a lot about this. What we have developed, what we are doing now is taking the robust amount of information, health risk information that's in the health risk screening tool, and we're connecting that information with clinicians, with telemedicine providers. In this case, we have partnered with Station MD, and we have built a data interface where the health risk screening tool health risk scores, along with the scores in each area of risk, are auto-populated into Station MD's electronic health record platform. And what this allows them to do is that whenever they are seeing a person who has the health risk screening tool that's scored, they will automatically get a very specific and concise report that details each area of health risk that's identified. And this will provide those clinicians, those physicians, with a risk profile that shows, okay, maybe they're high risk for aspiration, and they're high risk for bowel obstruction, and they're low risk for falls, so on and so forth, which can really help inform their clinical decision-making. This is a very exciting development and partnership that we are creating here. It's starting off to be available in Missouri. It's actually just rolling out right now as we speak, and there are other opportunities down the road for this to be in other areas as well too. And I mentioned health risk informed medicine. So this can be done outside of the telemedicine arena as well, because this clinical relevance document is the document that we developed to provide this concise information in a way that a physician can utilize this health risk information. And it can also be printed out or PDF'd and sent to the person's physician, ER physician, primary care physician, to provide that specific risk profile. And it not only gives the numbers, but it tells the clinician what that number means for that particular health risk number means for that person, providing the clinicians with significant and important information. So this is something that's very exciting. If you have interest in this, please reach out to us. Now, with that, we would like that pretty much concludes our webinar today, and we'd like to give a special thanks to the Georgia Department of Behavioral Health and Developmental Disabilities Division of Strategy, Technology, and Performance for their assistance and their collaboration on this presentation. We couldn't do this without the hard work that they've done in creating their mortality reports. Now, if you need help from us, please reach out to us. If you're an HRST user, all you have to do is on your login page, there's a little button that says Contact Support, and that's how you get to us. If you're not an HRST user and you'd like more information about the health risk screening tool, please reach out to us. You can visit our website at replacingrisk.com, or you can call us at 877-748-4778. If you should have any specific questions about the webinar today or from the webinar today and would like more information, you can contact us directly. My email address is craig@replacingrisk.com. Jonathan's is jonathan@replacingrisk.com, and we'd be more than happy to answer any questions that you may have. And with that, we thank you very much for joining us today. We hope you found this information helpful, and we look forward to continuing to support you as you support people with intellectual and developmental disabilities to live a life full of health and wellness and live lives that they love.